So this morning's presenters are coming to us from Imperial College of London, and it's my pleasure to introduce Doctors Matthew Prime and Yasser Bhatti, and they're going to talk to us on frugal innovations and surgery. Doctors Bhatti and Prime, let me hand it over to you.
Okay, well, thank you very much, Adrian. Thank you for inviting us to present. So our topic on frugal innovations and surgery, we are going to structure the presentation by going, next slide please. So we want to share with you a definition of frugal innovation beyond what is generally understood in mainstream media. We want to then move on into further identifying and understanding how these frugal innovations can be particularly useful and relevant to healthcare. We will also give you a little bit of a hint on our research on barriers on frugal innovations and how the challenges in adopting them in healthcare. And finally, what we want to really instigate here is a discussion around what further research needs to be done in order to make it most relevant and useful for surgery. Next slide, please. So the learning objectives hopefully reflect all those, the outline that we have structured. So we are going to share with you some of the emerging trends and concepts in healthcare innovation, one of them mainly being the focus on frugal innovation. We will look at some ways at how innovators are actually innovating frugally in order to achieve their objectives. And we also want to question whether these frugal and, or as I will also describe, reverse innovations, whether they have a playing field in terms of global adoption and diffusion of these types of healthcare innovations. And as I said, the last thing is to come up with some thoughts about research that can be useful for surgical innovations that are frugal. Next slide, please. So this section of the talk is primarily based on my PhD research, which empirically looked at defining frugal innovations from the perspective of how it's understood by social entrepreneurs. And I should say that there's probably two ways that frugal innovations are studied. One is, as I said, from the point of view of social entrepreneurs, small business startups that essentially have a social purpose rather than a for-profit purpose. And the other way that frugal innovations are generally studied is from the perspective of large corporations who seek to become more competitive globally, both for their home markets in the Western countries as well as in the emerging or the developing countries. But this definition that I will share with you is again drawn mostly from social entrepreneurs. Next slide. So the relevance of these frugal innovations for healthcare, just to give you a context, the colloquial understanding of frugal innovations would basically be that it is the sparing or economical use of money. And so it would seem that that should be very relevant for both high-income as well as low-income and middle-income countries. The high-income countries are facing demographic changes whereby there are aging populations. They're also faced with the challenge of the burden of chronic disease management, and all that, those demographic and disease issues are leading to exponential cost of healthcare delivery. But there's also issues around how market dynamics in certain contexts, such as the US, mean that the costs are increasing beyond the demographic and the nature of disease, and so the Affordable Healthcare Act was designed to alleviate some of those issues. In low-income and middle-income countries, of course, there's simply not healthcare. There's little healthcare available for the vast populations of both young and old, and where there is healthcare available, it's of poor quality. So we think that frugal innovations can help to remove some of these barriers and challenges that both high-income and low-income countries are facing. Next slide. So we want to show you a video of a very well-known example, highly narrated frugal innovation by General Electric.
Advanced electrocardiogram technology from GE. Small enough to fit in the backpack.
Very good.
Powerful enough to bring modern healthcare to places like rural India.
So you can see there are several issues that needed to be addressed in those local market settings in India, with that context shown in the video. And General Electric Healthy Imagination Division essentially describes this as a reverse innovation process, whereby products, devices, processes are designed in low-income countries for low-income countries, whereby which we look at them as frugal innovations, but then there's the potential of diffusing these frugal innovations to the high-income countries for equal or more benefit, and that would be then described as the reverse process of diffusion or reverse innovation. And so this chart here shows you a little bit about the different terminologies that are similar in some sense, and the rise of these terminologies over these last decade or so. With this chart was last updated in early 2014, and so it may have changed slightly. But the number one concept is reverse innovation, with then grassroots innovation shortly following that, and then the number 3 is frugal innovation. And there's other terminologies, but I think what we have to be aware of is that they're more or less talking about innovating for low-income, challenging contexts that face certain resource constraints, and what would the potential be of then adopting those innovations globally for the benefit of all of humanity. Next slide. So moving on from the colloquial definition of frugal, and then understanding better what frugal innovation is, as I said that I did a study of social entrepreneurs to understand how they innovated and how they perceived innovation in challenging contexts that face both resource constraints as well as institutional voids. So I didn't go out and ask them what frugal innovation was or what reverse innovation was or any of those concepts, but really to distill down into how they innovated and how they saw innovation was being done in their different sectors. So this was a meta-geographical and a meta-sectoral study of about 81 entrepreneurs, and it's a largely qualitative work whereby we looked at document analysis of their business plans, about 163 business plans, ranging from 2005 to 2011, We then did a number of interviews with these social entrepreneurs, innovators, as well as investors or academics who were mentoring them. And then further observations were done at the Global Social Business Incubator, where they convene annually to understand how better to scale up their enterprises. So it was a qualitative study using different sources of data that were then triangulated and very cross-verified and tabulated in order to come up with some meaningful inferences on what frugal innovation means to these social entrepreneurs. Next slide. And here's essentially a summary of the whole PhD, which was that, well, on the first row, that frugal innovation is largely, yes, about affordability, about the sparing and resourceful spending of money, but this involves both means and ends. So it is affordable both, it could be affordable for the producer, the supplier, and or it could be affordable for the end user. So there is it's both about process as well as outcome. The second row describes that it's about doing more with less. So it's about adapting those innovations to the local context in order to provide value addition. And so this value addition, as I said, if you are a large multinational corporation, then maybe efficiency is probably the foremost objective here. So optimization and efficiency of their processes for production. But if you're a small entrepreneur, then bricolage, or the French word for do-it-yourself or improvisation, means that you basically are forced to manage and do with whatever is on hand. So you have to come up with meaningful ways to improvise and deliver what you wish to achieve using the few resources that are available in that context. And the third row essentially describes that it's about scalability. It's about accessibility and scalability for large populations that don't have access to these innovations or services and products. So it's about many. So the definition, in other words, that we would like to leave you with is means and ends to do more with less for many. Next slide. I want to describe, using a case example, a little bit about the responses of one of these social entrepreneurs that I interviewed. And when I asked them what frugal, as I said, I didn't ask them exactly what frugal innovation was, but they did come up with responses that frugal is not cheap. There's a misconnotation around, I think, that frugal means low quality or cheapness. And what this chart essentially says, according to Porter's two strategies, that you can either have a cost leadership strategy, whereby you are providing affordable or cheap products, but they're not highly differentiated or high performance. At the other end, you might be providing standard or differentiated products which are high performance, but then naturally you would not be a cost leader any longer. And where these frugal innovators are really trying to position themselves is in that green cross, whereby they are trying to achieve both high performance as well as very low cost. So much easier said than done, perhaps, but here's an example. Next slide. So there is a social enterprise in India which provides prosthetic knees to large populations who cannot afford them free of charge. And what they originally had for a long time was this multi-axial, which is shown on the lower left-hand quadrant of this chart. They had this multi-axial prosthetic knee joint, which wasn't very user-friendly, especially for the Indian context, where people are used to crouching on the floor, and that is their normal way of life. So they teamed up with some students at Stanford University gave them this challenge of coming up with a very affordable prosthetic knee joint, which was high performance, and the team came up with the one that's shown on the top left-hand quadrant. Their claim is that it provides much greater stability, gait efficiency, and at a very, very radical low cost. So, as opposed to the very high performance $10,000 prosthetic knee joints on the top right hand quadrant, they were able to come up with this $20 prosthetic knee joint, which was termed as one of the top 50 inventions of the world by Time magazine in 2009. And here you if you could click the button, please. Thank you. Yes, so you can see that the previous chart nicely overlays over this example, whereby it shows you how Frugal innovators have been able to achieve extreme high performance at very radical low costs. Next chart. The other point about definitions around frugal innovations and understanding what they are, for many years, I think for the most part of the last century, we've been looking at technological innovations primarily. But what I found from my entrepreneurs was that, yes, technology innovation was very useful in order to overcome resource constraints. And resource constraints could be, machine, tools, technology, capital, labor, or skills and knowledge needed to innovate. But however, they also were equally or more so doing other types of innovations in order to overcome, for instance, the affordability constraints of their end user. And also the third challenge, which is institutional voids, which are essentially norms, regulations, patterns of accepted behaviors that govern market institutions. And so you can imagine that the markets are not very efficient in the developing or low-income context, and they needed to come up with ways in order to overcome those inefficiencies. Next slide. So this shows you that to overcome those challenges, they used a combination of, yes, technology innovation, but they combined this with social innovations as well as institutional innovations. And social innovations are innovations which are defined as where the primary value is accrued to society rather than to the private individual or to the business startup. And institutional innovations, again, they are about legitimately changing the institutions that govern your markets. So what we're finding, the question marks are showing the type of innovation which we think is the frugal innovation that's happening at the interstices of these three types of broad innovations, which are very well accepted in the literature. Next slide. So if we can now move on to some of the examples which we would like to narrate to you that we deem as frugal innovations. Next slide. So this is a book written about Aravind eye care. Back in 2011, the book was published. And this Aravind eye care was established in India in 1976 with the core objective of ending blindness in India. And their mission is to provide sight for all and to see everyone as one. So they seek to provide eye care to both the rich and poor equally with the same health care outcomes. And the principle is achieved through high quality, large volume, and a well-organized system. And even though it provides free services to 70% of its patients, they have a healthy margin of about 40%. And they've been able to do this in a number of ways. So one of the big challenges they faced was the import cost of lenses, which were about $200 a piece at the time, and they created their own Aura lab for the production of high-quality intraocular lenses and brought down the cost of those lenses to $5 a piece. They now produce about 700,000 lenses a year 3/4 of which are actually exported to other developing countries around the world. To my knowledge, to my latest knowledge, unfortunately these lenses are not exported to the US for various US FDA clinical approval process challenges. Next slide. This is an example of largely technology innovation, I would say, and it's called the Arbutus drill cover. So, inspired by challenges in Uganda and Malawi, where my colleague Matt Ryan has also worked in and experienced this firsthand, is that orthopedic drills can cost up to $30,000 US, and they run of pneumatic infrastructure in hospitals. So this infrastructure as well as these devices are simply not available in low resource context. So some innovative doctors, they came up with a sterilizable, reusable cover that they would wrap the standard commercial drill, which costs as little as $300, and so they're able to then perform the same types of surgical procedures that the high-end orthopedic drills would otherwise allow them to do so. And I think that they've been able to do about 4,000 surgeries in low resource settings using the drill cover, for which they're doing clinical trials. Next slide. So this is you may be familiar with this. Dr. Devi Shetty was Mother Teresa's personal physician, and seeing the challenges of cardiac surgery in India in 2001, he came up with Narayana Hospital, which is now Narayana Health conglomerate, and there've been a lot of empirical studies on how they've been able to reduce the cost of cardiac surgery, but yet maintain very high levels of health outcomes. And so the chart on the right-hand side shows you that Narayana Health is able to provide cardiac graft surgery as low as $2,000 US versus whereby US Medicare may pay up to $40,000 US. And the number of heart surgeries is far greater than the number of surgeries that are done at, for instance, the Cleveland Clinic. And the health outcomes are that the quality indicators suggest the 30-day mortality rate from coronary artery bypass surgery at Narayana is 1.4% versus 1.9% at best in the US. So next example. So I think this has been talked about for a long time, and we were actually surprised to see that the latest clinical trial on this was published in January by the New England Journal of Medicine. And hernia repair is the most common operation in the world, whereby about 20 million operations are performed annually. And the commercial net that's used in hernia repair costs as much as or greater than $100 US. And there are claims that the factories or that produce these commercial healthcare hernia repair nets are the same ones that actually produce the widely available Mosquito net, which costs a fraction of that, probably in the range of $1 or $2 US. And that's for a whole net that you would cover a bed with for protection against malaria. But the New England Journal of Medicine paper in January shows that the health outcomes of using Mosquito net are not significantly any less than using commercial hernia repair nets. Next. So I think to sum up these two sections of the presentation, so we've got Dr. Devi Shetty here saying that for 80% of the world's population, if they require a heart operation, unfortunately they face death. And that's not acceptable to him, whereby he's on a mission to be able to provide cardiac surgery to not just India, but to the world. And so Ascension Health, which is the largest non-profit healthcare system in the US, has now partnered with Narayana to build Health City Cayman Islands just off the coast of Florida, with the opportunity to both learn from Narayana on how to manage better healthcare at much lower cost, both for the benefit of the United States as well as hopefully being able to diffuse those lessons to other countries around the world. So at the one end you've got frugal innovations, and at the other end there's this talk about reverse innovating so that we can learn from those frugal innovations for everybody. So that sums up the first 2 points, and I'll pass it on to Professor Park to possibly entertain any questions.
All right. Thank you, Yasser. And a quick question to you before I go around for some comments. How central to the efforts of frugal innovation is the concept of securing intellectual property? Is that central or not central? Is that a key element of this or not?
Again, I think it depends on who is innovating. So certainly if General Electric or the multinational corporations are frugally innovating so that they can be more competitive against competitors, then for them intellectual property is paramount. However, for the case studies that we've looked at, if it's Narayana or if it's Aravind, or if it's doctors who are trying to encourage the greater use of mosquito nets for hernia repair, then possibly we would argue that maybe intellectual property is not so critical, because their primary purpose, as I said, their primary objective is social, is to provide this health care to global populations affordably and scalably. And a lot of these social enterprises are willing to share their lessons with anybody else who can adopt them. So for instance, there's in Mexico and in the US, there's Sala Uno, another social enterprise that is mimicking what Aravind is doing in India. And they're freely sharing knowledge with them as far as we know.
Okay, thank you. All right, well, we know that surgeons, we tend to be problem solvers, we tend to be pretty innovative. I'd like to go to one of our regular participating centers. Let's go to Mount Sinai in New York. Let's see what we have this morning. Morning, see a bunch of friends and faculty there. Dan, I see you there, one of the most innovative surgeons I know. Dan, how do you think that, a couple of questions, how do you think that, being a little more American-centric, American surgeons will respond to innovation that doesn't protect or secure their ideas, A? And B, do you think that there's, within American healthcare at this point, that there's appetite for anything other than frugal innovation, except, of course, for pharma, who can charge what they want with impunity? But do you think there's an appetite for any other kind of innovation right now?
Well, I think that frugal innovation is a big challenge in the United States. One of the areas where I've tried to be frugal and innovative is in TEP hernia repair. There's been a lot of criticism about laparoscopic hernia repair as being more expensive and yet reimbursed at a lower rate. And so in trying to address some of the costs, I do a TEP hernia repair that does not involve a balloon dissector. It just involves using getting your finger in there and doing blunt dissection to open up the preperitoneal plane. And then instead of using any fancy, preformed mesh, we just use we're not allowed to use a piece of mosquito netting. I would love to use that if possible, but we use just a piece of plain 6x6 large pore mesh, which is as close as we can get to mosquito net in the United States. However, so I think it's great, and I enjoy trying to do a low-cost hernia repair, and yet it has not been welcomed throughout my medical center. A lot of people think I'm a little bit nutty for using this approach, and I think that the reason that it has not been widely disseminated, is that there are a bunch of barriers in the United States to implementing frugal innovations. I mean, first of all, it's, surgeons like tools. They like new and improved. They like smaller, better, faster, upgraded, latest iPhone, biggest screen, lightest weight. It's not sexy to do a hernia repair, with finger dissection and with a plain old-fashioned, piece of mosquito net. There's no incentive for the surgeon in most institutions to save money. In many institutions, surgeons have a vague understanding, or maybe they'll get a monthly report on how much they spend in the operating room, but there are very few incentives that make a surgeon be aggressive about saving money in the operating room or elsewhere. In terms of innovators, if you're trying to invent a new product or a new process in the United States, in order to get the funding, the funding that you need to secure your intellectual property and to secure that patent, it needs to be a profitable device. So if you're creating a new operation or a new process which is going to sell for $20, like a simplified knee joint, the business model often doesn't work in the United States because there are so many regulatory forces in process that you can't get your, there's so much overhead involved that unless your product is expensive, you can't overcome these limits. So I think between the problems with incentivizing surgeons to be frugal, the problems with the regulatory environment that we have in the United States, and in terms of the fact that surgeons are kind of, gadget heads who like the latest, coolest, sexiest device, and lots of frugal innovation is the opposite of that, I think it faces barriers in the United States.
Those are great comments and great insights. And let's, thank you, Dan. Let's go now to IRCAD, University of Strasbourg in France, and really one of the most innovative centers in Europe, really in all of the world surgically. And I'd like to again see several of our friends and colleagues there. Bernard, let me ask you a little bit. There's a huge focus on innovation now at the ESU and of course through IRCAD. Do you feel the same cost constraints that Dan Heron was just talking to us about when you guys are looking at innovations? Is it the Western markets? Is it the developing world? Where are you targeting your efforts?
First of all, I would like to congratulate the speaker because it's very interesting. It's quite innovative ideas about innovation because it's as it was just mentioned before, the problem in our country, Western United States, France, etc., is that usually we are looking for high technology because we feel as a surgeon that we need high technology to perform very simple things. And I would say that at IRCAD the innovation program is a little bit in this direction, high technology, very heavy technology, to try to understand if we can do better, maybe sometimes to be able to spread this innovation. But it's true that initially that represents a quite large amount of technologies that we cannot imagine being spread in all the countries all over the world. So we are probably in quite the same situation as the United States in terms of innovation process. But probably that's something that we should add in the portfolio of research institution like the Imperial that did it. And I think that probably in France also, that's something that we should include in our portfolio and looking a little bit at this frugal innovation and not looking only on the very heavy technological innovation. I have maybe two guys with me who will ask you a question. The first is Ben from fellows from Stanford, so maybe some ideas from Stanford.
Hi, thank you for your talk. It was very interesting. I wanted to also kind of piggyback on this idea of a lot of institutions in the Western Hemisphere are focusing on implemented in places that have a lot of resources, so high-tech innovation. But I think one barrier to R&D centers that have a lot of resources developing innovation for the developing world is that we may not know exactly what the needs are in these developing countries. And I was wondering if you all had any ideas on or methods of sharing the needs of these developing countries with centers that have the resources to do R&D and come up with solutions for them.
So Matt, let me direct that to you. We've got one or two more questions or comments, so we're going to have to pick up the pace a little bit here going through. But Matt, let me direct that to you. What do you guys find as the best process to establish an appropriate needs assessment, to scan the horizon for problems for which you feel you may be able to provide solutions in the developing world?
So as I think Yasser said, I'm an orthopedic surgeon, and I've actually practiced at Imperial, but I've also spent time practicing as a surgeon in Malawi. And I think in terms of doing a needs assessment, you have to go there and you have to understand the problems, and you have to take advice from the people there with their problems. So if you look at what GE did to build the ECG, what they did was Jeff Immelt, who's the CEO, set up an R&D centre in Bangalore, and he said to the engineers there, look, we really want to access the Indian market, but our current device is not allowing us to get any access here because it's too expensive. So they stripped out the ECG, it took off the digital display screen, they replaced all the buttons with 2 buttons, they replaced the wheel that the ECG printout comes on with the wheel that you get from a bus ticket, and they were able to produce a device for $800. Now to put that in perspective, the Mac 400 ECG that you saw in that movie has sold $275 million worth of product up to 2012. So what they gained was this kind of knowledge from being in Bangalore and asking people there what the problem was. And in the second half of this talk, what I'll do is I'll show some kind of more early stage entrepreneurs and innovations. And a common theme is that really the knowledge that they do to make those devices they've got from going there. So there are, I have an example of a device which is a partnership between Malawi and the London School of Tropical Medicine, and they really got that knowledge by being in Malawi, in Botswana, and in Kenya to understand what the needs were.
All right, let me go for a quick comment and then a question we have out there. I want to try going to Wes Blakesley. Can we go to Wes Blakesley? Wes essentially ran tech transfer at Johns Hopkins for several years. He's now engaged with us here in Annapolis as we look to launch our own innovation center. Wes, very quickly, 2 questions for you. One, do you think that in America surgeons can engage in frugal innovation, maybe even social innovation? Are there protections that they might have they might not be aware of? And what are mechanisms that you've come up with in your previous experiences where you really are able to do a survey of needs in environments that might not be as accessible to as we might think they would be?
Good morning, Dr. Park. Can everyone hear me?
Yes.
Okay, great. And good day to everybody around the world. I think that we can do frugal innovation in the United States. It's not easy. Some of the comments pointed out, with regulatory hurdles and otherwise, it's difficult to simply put some new technique or a simple new product in place, but there should be no barriers at all to doing frugal innovation. I think you see a lot of it that goes unnoticed because doctors, naturally do a better job and learn things as they go, and they spread that knowledge by conferences such as this one, and it doesn't get a lot of fanfare, but a lot of innovation takes place that way. There was some comment before about intellectual property. The most important part of intellectual property is when you need to spend hundreds of millions of dollars in development, and have a way to get your investment back. So then you have to have some intellectual property protection. I think that it is possible also in the United States to do the kinds of innovation that to address products around the world, but I think the point that was made about needing to have boots on the ground in the environment where the innovation needs to take place is essential, because it's very, very difficult if you're in an area like the United States with the kind of facilities that we have to be able to appreciate the issues that you might have in the field. But a lot of our physicians, Dr. Park, you're one of them, do regularly travel to those parts of the world that need innovation and bring that knowledge back. So I think we can do it. I think there are places that we are doing it.
All right, thanks, Wes. And before we head back to Matt now, Phil Shower at Cleveland Clinic, Maine. I think, Phil, you had a question.
Yeah, Adrian. Thanks for bringing the subject on. This is fascinating. I want to commend speakers on bringing this topic for discussion. This concept of frugal innovation can literally bring healthcare to millions, if not billions, of people that would otherwise not receive it. And it's just amazing the differences in cost. I mean, the $20 knee joint versus the $10,000 knee joint. And then we have these $1 million robots in our country that really there's very little evidence for a lot of these procedures that they make any difference. So the incredible disparity of cost versus outcome, it just boggles my mind. But I guess one of my questions, or two questions, the $20 knee joint, I don't get it. How a lot of the cost of that $10,000 knee joint is development, R&D, testing to make sure there's safety, and then post-market research to prove that it's safe. So how do you do that with a $20 knee joint? Where do you get the money to do all this testing and validation? So that's one question. And then secondly, I was at a conference a few years ago in the Middle East, a big trade show, and they were displaying a Chinese company staplers that looked exactly like the staplers that we would see from Ethicon and Covidien. They looked exactly like them, but they were sold at a fraction of the cost. And I suppose that they were just copying these instruments and selling them at a lower cost. So how do you differentiate that, which is copying technology, from frugal innovation? Would you call that frugal innovation? So those are two comments and questions I throw at our speakers.
Those are great comments and questions, and you're teeing Matt up for the next part of the talk. I suspect there are fewer med-mal attorneys in the Indian subcontinent than we're afflicted with here. That might have something to do with it. But Matt, let me hand off. This tees up the next section. There's obviously a lot of interest in this discussion, so we've had some good discussions. So unfortunately, we're going to have to move through your section a little more quickly now.
Okay, so we go back to the slides and I'll get started.
So if you don't, if you just keep in mind Dr. Shower's questions, and I think you can address them through what you next have to talk about.
Yep. Okay, so for the second half of this, I'm going to try and cover two things quite rapidly. The first one is trying to understand more how these frugal innovations in healthcare are actually doing what they're achieving more with less. And the second half, I'm going to talk a little bit about the cognitive biases and the barriers that some of these innovations may experience when they try to enter developed markets. So the first part of this is trying to, if you go to the next slide, the first part of what we wanted to do is try and identify, frugal innovations for frugal innovations. And so through an iterative process, we developed this tool, and this is really based on the empirical work that Yasser's done, and we picked out the dimensions of frugality, of affordability, adaptability, and accessibility as our criteria. And if they satisfied them, then we classified them as a frugal innovation. So we go to the next slide, please. So what we wanted to do was test this tool, and we did this at the World Innovation Summit for Health conference in Qatar in 2015, and we evaluated 28 generic healthcare innovations, and Yasser and I independently interviewed all of the innovators. That was 56 interviews and over 20 hours of interviews. So if we go to the next slide. And we identified 15 of these innovations as frugal. So the purpose of that really is that a lot of the literature is based around the MAC 400, Narayana, Aravind, and we said, well, actually, and in fact one of the previous comments was, there is lots of frugal innovation going on out there, and how can we try and identify more of it so that it can be used and disseminated? And actually using this tool, we had a good proportion of agreement and a good CAPA score. And these are the 15 innovations that we identified. The Arbiter's drill cover people have seen. The RoboHand is an interesting device, and this really picks up on the question around intellectual property. So RoboHand employs 3D printing to make customized prosthetics for amputees, and all of their CAD designs are open source. So what that allows is anyone, anywhere, can make this customized prosthetic for themselves. We also came across something called Peak Vision, which I'm going to talk about a little bit further, and that's really employing digital platforms. So they're really examples of products. And then in terms of processes, Promudia, which some of you may or may not know, is a microfinancing company based in South America or across South America. What we saw there is that they leveraged their loan network to provide a subscription-based healthcare for women and children, and then a slightly more extreme frugal innovation is the Shudavazi healthcare model, where they used Indian traditional healers to deliver protocol-based care to rural Indian communities. So if I can go to the next slide. So after performing these interviews, we did a thematic analysis of the field notes and innovation-related documents, and we tried to understand the dimensions that enable frugal innovation in healthcare. And these are some of the dimensions that we found. We identified 26 different themes, of which 19 were considered to be different. So let me talk through some of these. So the first one, and I'm sure many people would probably not think of this necessarily as frugal, but is digital technology and the application of the cloud. Now, the benefit of using digital technology is that it can be cheaper, it can be better adapted, and through the cloud and through platform, it's scalable. So Peak Vision, which I'm going to show you a video of in a bit, is basically an ophthalmoscope delivered on a mobile telephone. And as you can imagine, that has a lot of incredible benefits in terms of doing retinoscopy and a whole manner of eye tests. We saw 3D printing as being interesting, and the reason 3D printing is interesting is because it disrupts the logistic chain. So you don't have to have a courier deliver your implants, you don't have to have lorries on the roads, you can just deliver a device remotely. And actually this is how RoboHand does it. So they're based in South Africa, but they can actually do prosthetics for people in the Congo. Product simplification, as we've seen with the MAC 400, is a strategy that's employed, but we're also seeing product simplification with the Arbiter's drill cover, as we've discussed, and the Pomani bubble CPAP as well. So the Pomani bubble CPAP is interesting. That's actually originates from the University in Texas, where the PhD student went to Malawi, spent 2 years in Malawi doing all of the field research, boots on ground, qualitative research to understand the need, and then partnered with 3D technology, which is 3Stone technology, which is also based in Texas, to develop this CPAP machine. So the interesting thing about this is it's very much a stripped down CPAP machine, but it also comes with a toolkit inside the machine, so it can be and a set of instructions if it breaks. Because one of the things you find if you're in rural Africa or even anywhere in Africa really, is trying to get parts is very difficult and expensive. We saw bundled procurement, where two examples of this are Janmar and the mother's delivery kit. So most childbirth happens in rural villages, and actually it can be incredibly unsafe. And the World Health Organization has released guidelines on equipment that's required to do a safe, sterile home delivery in a rural setting, and using those equipment guidelines, Janmar and Mother's Delivery Kit have been able to produce a kit for $5, whereas if you bought the assembled kit yourself, that would be $20. Now, what that means is they can sell that kit to charities, or they can sell it to mothers themselves. You'll need to spend a little, they can use that pricing strategy to get people safer care. We also saw shifting the location of care as being key, and Peak Vision are able to deliver eye care tests remotely. Furthermore, task shifting, where they're able to enable people who are less medically qualified to perform diagnostic tests, was critical, and they actually have a really interesting study where they compare retinal image attainment by consultant ophthalmologists from Moorfields versus a head teacher at a primary school in Botswana, and they show absolutely no difference in the actual diagnostic image acquisition. And just to finish up, some of the other things we saw were cross-subsidization and tiered pricing strategies, and the harnessing of networks that are already there, and we see that with Promuja and Sugavazu. So Sugavazu Healthcare is using Indian traditional healers, as I said previously, but why that's interesting is because the group behind that recognised that rural communities have trust in these traditional healers, and they could leverage that trust, but make primary care safe by making the traditional healers follow protocols. So if I just go to the next slide. So this is it's quite difficult sometimes to conceptualise some of these strategies. So if I show you the video of, I don't know if the video is coming up here.
The best estimates we have are that there are about 39 million people in the world who are blind. We believe 80% of that is avoidable.
Peak is a portable eye examination kit. We use apps and simple adapters to mobilise the eye care. Every part has been designed with the non-specialist in mind, so we can extend the access to eye care globally.
Traditional methods for testing eye disease have been very expensive and required a lot of equipment that's usually been designed for a hospital setting.
We're here at a local clinic in Guatemala, introducing the technology to ophthalmologists and local healthcare workers to see how it fits into their practice.
The main problem is that most of the ophthalmologists live in the city, and 70% of the population live in rural areas.
With Peak, we can send just one person. They can access any location, and they can perform some really high quality eye examinations. To start with, we have the visual acuity test. It allows us to very quickly get an evaluation of how well someone can see. It's replacing a standard eye chart that is a lot smaller, more portable and easier to use. We can then use our SightSim tool to communicate to the patient and their family how well they can see at the moment, compared to how well they could see if they could access the right treatment. With Peak Retina, our low-cost ophthalmoscope adapter, we can look at the back of the eye too.
Looking at the retina is an essential medical examination.
The Retina adapter is the most exciting device I've ever designed. It is incredibly simple, and yet it will change the way we look at eyes.
The moment the retina filled the screen on a mobile phone was the most defining moment of my career.
It's an amazing thing that you can do with a phone. This is a really huge change in eye care.
Most eye diseases can be treated, but there are millions of people going blind because they are not being reached. With Peak, in clinics like this, we can really take eye care everywhere.
So next slide. So in the second half of this, what I'm going to do is discuss some of the barriers that some of these frugal innovations might face. And I think that we could appreciate that it might be a stretch to get Indian traditional healers to provide healthcare across Europe and North America, but as we can see, Peak Vision could definitely be something that we use. So if we go to the next slide, I'll skip over this. One of the things that we talked about, if we could get the next slide? Yeah, so one of the things we have mentioned already is the low-cost mesh. And if I just read this, in summary, this showed that a low-cost mesh can be used in hernia repair with excellent clinical outcomes that do not offer that do not differ significantly from those achieved with commercial mesh. These results support the use of low-cost mesh for hernia repair in resource-scarce settings. Now, the obvious question that comes from this is, if the results are the same, why aren't we using these in high-income settings? And I think some of the comments at the half-time break supported the barriers and discussed the barriers that these might be. Now, I don't have much time left. If I go to the next slide, I'm going to present some of the work done by a colleague of ours here at Imperial, who is a GP and a consultant in public health and also a clinical lecturer at Imperial. And he's done a lot of work around the Brazilian family health strategy and whether this could potentially be adopted in North Wales. And what he found was there was a huge amount of resistance to adopting innovations from elsewhere. So if I just read the first example, what can we possibly learn from a developing country like Brazil? Was a comment that he had from the Department of Health in the UK. And actually, we don't know what we can learn unless we do a pilot study. And the comment then was, well, no evidence that a pilot project would work. But obviously there's false logic there, because the reason you do a pilot study is to see if it works in the first place. So we'll go to the next slide. So he has just completed a Harkness Fellowship at NYU, and as part of that, he interviewed 11 academics, consultants with experience of attempting to translate policies or innovations from low-income settings to high-income settings, and he found two key themes. One was that there was a prior expectation of innovations that emerged from low-income countries. So here is a quote: they hear Africa and they think there can't be any good services. And the second thing was this perceived context similarity. So we're much more likely to adopt innovations that come from settings that we're more familiar with. So in America, that may be Canada. In the UK also, we look towards America. So we go to the next slide. So he performed a randomized control trial where he did a survey of 10,000 public health academics, and he invited them to participate in the survey, and he randomized the survey that people got into two sections, and the only thing he changed was the source. So as you can see in abstract 3, you either got Oxford University or Mzuzu University. So if I go to the next slide, and although there wasn't a difference between, there wasn't a significant difference between abstract 1, 2 or 4, there was a significant difference between abstract 3. And what we think is that if you think about the amount of research that's consumed around the world every day, or produced around the world every day, if we say 25% could be subject to these biases, then that's a huge amount of research that potentially we could miss out on. And if you translate that to innovations, where we have these prior expectations and we rely on perceived context similarity, then we are at risk of not adopting these innovations. Now, I've skipped through that quite rapidly. If we go to the next slide. So our current findings are from this part of the research is that research or innovations from low-income countries could be discounted early, and this is due to these prior expectations and context similarity. And there's also stereotype application. Although this was less than we had anticipated, and that's because stereotypes are complex, personal and variable. So I think at this stage what I might do is just run through the conclusions of our topic and then go back for questions after that. So if we go to the next slide and the next slide after that. So in summary, frugal innovation is a means or end to do more with less for many, and it encompasses affordable, adaptable, accessible and scalable innovations. Dimensions employed by innovators to achieve frugal innovations include simplification, task shifting using protocols and harnessing existing networks, economies of scale, technologies such as digital platforms and 3D printing, and critical is changing the location of care, moving it more towards the patient rather than in big institutions. Frugal innovations will face significant barriers, and I think those came across through the questions. And one of the things that we want to explore in the next stage of our research is how can surgical specialties in developed countries adopt and benefit from frugal innovations. If I just go to the next slide, please. So we recently received a British Research Council grant to investigate the following questions, and that is, how can we identify, evaluate and prioritise frugal innovations in surgery? How have they been developed, by whom and where and why? And that really gets to the question of what do we need to understand in terms of understanding the needs of the context in which we're innovating. How can these innovations be translated into other contexts? So how could we take an idea from Malawi or Uganda and translate it to the US, UK or Europe? And how can frugal innovations be nurtured and enhanced beyond the cost concerns? And again, this is all about this reversibility process. How can we in the West really, or in the Northern Hemisphere, really benefit from these advances that we're seeing elsewhere around the world? So sorry I've had to rush through my section of that, but if we go back to Professor Park, we can possibly pick up on some of these points.
Well, thank you, Matt, and I think what this presentation has revealed to us is that we've paid far too little attention to this topic through the course of this conference and our broadcasts, and we clearly need to come back through some of the questions that you've just put forward that are going to be the focus of your research through this grant. You'll be answering some of the questions that Dr. Schauer, in fact, just put to you. And so we do need to curtail the broadcast at this point, but I want to thank both of you, Matt and Yasser, for very stimulating and edifying presentations. Again, you've identified to me that we need you spending more time on these kind of topics perhaps through this conference, and so we'll be looking to hear of the fruits of your research going forward. So thank you both very much for taking the time and for sharing your expertise with us.